So if some people are new and don't know me, I'm Rashmi. I'm a hematopathologist and a molecular pathologist and I work out of Sunnybrook. Um, so so I'm just going to give you a little bit of a caveat. This is actually not like this isn't going to be like a bilineal or like two populations of blasts. It's actually one population of blasts. It's just a question of like two different diagnoses. And I'm kind of presenting this as an interesting case and hopefully maybe generate a little bit of discussion around the final diagnosis. Okay, so we'll just start. And I apologize, I'm really not good with computers, so if there's some sort of weird technical difficulty, I plead guilty right now. Okay, so we'll start. So for the objectives of this talk, I thought we could review the diagnostic criteria for a few different entities, namely blastic plasmacytoid dendritic cell neoplasm, which is a fairly rare entity, as well as leukemias with KMT2A rearrangements. And then I'll just walk you through all of the ancillary testing that we did for our case. And then I'll briefly touch on targeted therapy for hematologic neoplasms with KMT2A rearrangements. Okay, so we had this very interesting case that presented last year. So it was a 95-year-old gentleman. He has a fairly unremarkable past medical history, a cholecystectomy, a TURP, a product cystic lesion in 2022, which was negative on FNA and must have resolved itself after FNA. As well as a H. pylori infection, for which he had completed about 2 weeks of treatment prior to presentation. So he presented to the ER with bilateral pitting edema to the ankle. In the emerge, they wanted to rule out DVT. Dopplers were negative, and the chest X-ray was unremarkable. Low albumin was noted on the calcium panel, and a pancytopenia was noted. Hemoglobin was 107, the WBC was 3.3, and platelets were 76. And so since the acuteness of the patient's presentation sort of resolved itself, namely that this person didn't have a DVT or PE, the plan was for the patient to return to outpatient clinic for workup of his pancytopenia and low albumin. It's unclear as to when that follow-up appointment was going to happen because about 3 weeks later, he presented again, this time with left upper quadrant pain. And then on prompting, the patient endorsed B symptoms, mainly unintentional weight loss, leading to loosening of his waist on his pants. That was pretty significant. It was about 1.5 inches. In terms of how much his clothing had loosened. He also admitted to having night sweats and generalized weakness for 2 months, which he didn't seem to mention on the prior admission. So in terms of the physical exam, cervical and inguinal lymphadenopathy was palpated bilaterally. Left upper quadrant tenderness was elicited, and the spleen was palpable. And then there was right-sided pedal edema that was still present. So a CT chest and abdomen was ordered, and there were multiple bilateral lung nodules of up to 2.8 centimeters in size. There was bilateral supraclavicular, axillary, mediastinal, and hilar lymphadenopathy of fairly large size nodes up to 1.8 centimeters. And splenomegaly of 17.3, which was about 6 centimeters larger than the last time he had a CT, which was in 2012. And then abdominal, pelvic, and inguinal lymphadenopathy of up to 2 centimeters. Okay. So on the CBC at that time, his hemoglobin was still stable at 107. WBCs had increased a little bit to 4.8. Platelets were 120, so just mildly reduced. Neutrophils were normal at 3.36. There was some left shift. Lymphocytes were 0.96, and there were these other cells of 0.2 times 10 to the 9. So on the blood film review, there were a few small cells that were seen with deeply basophilic cytoplasm. And at the time, they were favored to be activated lymphocytes, but they were abnormal enough that flow was activated and showed an abnormal cell population. I'm not going to tell you what it is. Because the bone marrow basically shows the same thing. So I received the bone marrow. And so this was the bone marrow aspirate. And so you can see that there are these sort of blastoid looking cells. So they're basically blast equivalents. And you can see they're sort of eccentric. They have eccentric nuclei with these little, one could say, tails of cytoplasm. There is still background hematopoiesis in terms of the erythroid lineage is still there, although reduced. And then there are a few pelviroid neutrophils that you can see in the background, but there is some granulopoiesis that's still there. And megakaryocytes, I didn't take a picture of them here, but they were present with some hypolobated forms. But the majority of the cells were basically these strange cells, comprising about 80% of the bone marrow aspirate. So, and you can see that on the bone marrow biopsy. So he's 95, and this is a very hypercellular marrow. You can see that it's packed with cells. There's some tissue dropout, but you can still see quite a bit of morphology in these areas. So then this is a higher power view of that area, and you can see that there are these aggregates of immature cells. You can still see megakaryopoiesis in the background. And then this is a 40x view. And so in addition to these sort of immature cells in the background, you can still see erythroid cells as well as some mature granulocytes. So you can see there's a few mature granulocytes. So this matters because when you see the IHC, you kind of need to know what cells are present and what's in the background. Okay, so immunohistochemical stains were done, and flow was done as well. So I'm going to show you what was seen on immunohistochemistry, and we'll supplement with what was seen on flow for stains that are obviously not present by IHC. So these cells that look very immature are CD34 negative. And you can see that the stain is working because the vasculature is outlined by the IHC. And so, as I mentioned, there is granulopoiesis in the background, diminished, but still there. And so that's what we're seeing here, these scattered mature granulocytes in the background. But the majority of the specimen is still negative for MPO. So that's myeloperoxidase. So lysozyme is another myeloid marker, and as you can see, it's very similar to what the MPO is showing. So the mature granulocytes in the background are staining positive, but the immature cells are not. And then, so then this is to help understand some of the staining that you'll see in following. So CD3 stains T cells, but can aberrantly stain other cells. And what you can see here is that there's a sprinkling of CD3 positive cells in this specimen, and most likely represent background benign T cells. This is in contrast to CD4. So CD4 you would expect to normally stain just a subset of the CD3 positive cells, but here it's actually staining our immature cells quite strongly, in fact. So we can tell that our cells are CD4 positive. And then if you look here, the CD7 is also staining not only T cells in the background, which are likely these strongly staining small cells, but also a subset of our immature cells in the background. So it doesn't look quite like the CD3 stain. It's also staining these immature cells. So what we have now is at least subset weak CD7 staining and fairly significant CD4 staining. And then, so this is CD123, and this is a specific marker for, well, not quite specific. So it's a marker that stains plasmacytoid dendritic cells, but it also stains myeloid blasts. And so on a low power view, you can see that it's pretty much staining the majority of the cells in the specimen, and you can appreciate that on a higher power view here. Okay, so in terms of other stains, this is our population of interest, this sort of teal colored population. It's CD19 negative. These are our mature B cells. And so you can see that this is not CD19 positive. It's MPO negative because here are granulocytes that are staining for MPO. It's TDT dim partial, and then it is not staining for cytoplasmic CD3. So it is not of T lineage, even though it is aberrantly expressing some T cell markers such as CD4 and CD7. And so that you can appreciate that here. It isn't as strong as our benign T cells, but a significant portion of that population is staining for CD4. It is 11C negative. 11C is a monocytic marker, and it is CD14 negative. So here we have our mature monocytes. They're MPO positive and CD14 positive, but our aberrant cells are MPO negative as well as CD14 negative. And so that'll matter later on when I talk about diagnostic criteria. So the abnormal cells are negative for lineage markers, cytoplasmic CD3, CD19, and MPO. They show immaturity with expression of TDT, and they do not show, oh, sorry, that's supposed to be monocytic differentiation. So negative for CD11C, 14, and 64, which I didn't show here. So since we were suspecting leukemia, upon looking at the morphology in the bone marrow, FLT3 and NPM standalone PCR testing was done, and the neoplasm was basically negative for FLT3 ITD, for tyrosine kinase domain mutations, and for NPM1 mutations as well. We did NGS on it on our Oncomine myeloid assay, and it showed low-level NRAS mutations. And so even though these are in the same codon, they were actually not. So these were in the same codon, two different clones, and then this Gly13 was not in cis with either of these. So it just might be subclones within the population. And then interestingly enough, our RNA panel was also done, and it came back with a KMT2A MLL-T10 fusion. And so this is a very interesting finding. So luckily at that time, we had access to optical genome mapping through the University Health Network. And so I just want to briefly touch on the use of it. So optical genome mapping basically requires extraction of ultra-high weight molecular DNA from fresh tissue. DNA molecules are basically labeled enzymatically at a specific sequence that repeats approximately every 5,000 base pairs. And since this, even though there's a periodicity of about 5,000 base pairs, it's not uniform across the genome. And so what ends up happening is that the label actually ends up providing a way of almost banding the DNA molecule similarly to a karyotype. And so the labeled DNA molecules are then loaded onto a chip, which straightens out the DNA. And this is done in a nanochannel array. And the molecule is then imaged across its total length. And then given the enzymatic labeling, each molecule will show a unique pattern of bands. Then the images are converted digitally so that they can be processed bioinformatically, and then they're assembled digitally into a genome to find structural rearrangements. Oh, sorry. Okay, so I just want to talk briefly about the advantages of optical genome mapping here. So the advantages to OGM are that because the DNA extraction allows for very long molecules to be extracted, you can actually detect structural variants to a very low resolution. So there's no need for PCR amplification, and as a result, you don't get PCR bias incorporated into the analysis. And also you may minimize, and because there's no tissue culturing involved, there's no culture artifacts in the genome that you collect. So studies have been done and show that overall it's less costly than whole genome sequencing in order to detect variants, to detect structural variants, even at low variant allele frequencies. And you can get higher coverage basically at a lower cost. And parallel studies of OGM compared to other conventional approaches have shown it to outperform karyotype FISH and chromosomal microarray in certain aspects. And I'll go into the disadvantages shortly. So basically, this kind of gives you an idea of, so this shows you how conventional karyotyping works, and then this is what you would get in OGM. And you get a Circos plot that basically allows you to plot rearrangements across here. So this 821 rearrangement is represented by this Circos plot. So in terms of disadvantages, the OGM platform can't detect rearrangements between centromeres or the telomeres of chromosomes, and so balanced whole arm translocations may be missed, and as well as jumping translocations and end-to-end telomere fusions. And it cannot detect ploidy changes or clearly resolve clonal structure. And Adam Smith, this is actually from Adam Smith's review, and he goes into a very detailed explanation of how OGM works and the information that you can glean from it. And his talks on OGM are quite excellent. So if you ever get a chance to listen to that, then I would suggest that you do. So in terms of the optical genome mapping of our case, it actually showed a number of different aberrancies. And so the first one was a 3-8 translocation, as well as a 10-11 translocation. So that was borne out by our RNA assay, because this is what leads to the KMT2A MLLT10 fusion. In addition, it also showed a deletion of chromosome 12p involving the ETB6 gene. And so this is just sort of a higher power view of what was happening in the translocation 3-8. And so this basically is a rearrangement involving a region close to MYC. And it's a rare breakpoint breaking in the TBC1D5 gene, and it's near the SAPB1 gene, which is interesting because that gene is often overexpressed in lymphoid disorders. And so that's of interest. So this explains the chromosome 10-11 translocation. So this is a complicated aberrancy. So basically what's happening is, So what's happening is there's an insertion of KMT2A into the MLL10 gene, and there's a translocation which also disrupts the gene. And so basically, like, both events occurred at the same time, and since they involve the majority of the sample, and but apparently this is well known to happen. They're often multi-segment rearrangements and cryptic insertions involving KMT2A, and so it's interesting that the OGM managed to catch that. And then also, as I mentioned, it deletes the ETB6 gene. Okay, so this was all very interesting information. And basically, our differential at that time was an entity known as blastic plasmacytoid dendritic cell neoplasm. The KMT2A rearrangement, however, throws that diagnosis into a little bit of a it just basically throws a wrench into that diagnosis, and I'll explain as I go through this. I'll explain why. So, okay, so basically, blastic plasmacytoid dendritic cell neoplasm. It's a very rare condition. The estimated incidence is 0.04 cases per 100,000 individuals in the U.S. As in our patient, it occurs in elderly patients in the seventh decade of life with a 4 to 6 male to female predominance. Patients usually present with non-pruritic skin lesions. Often there are multiple patches, plaques, or nodules, and they vary in size and color. So they can be brown to violet to xanthochromic. And they often involve the upper thorax, head and neck, and upper extremities. Interestingly enough, our patient did develop a lesion as he was undergoing therapy. So he had a chest lesion, and so this was thought to be involvement by the neoplasm that we have here. So in terms of cytogenetic and molecular alterations in BPDCN, monoallelic and biallelic ETV6 deletions, like what was seen on OGM, can be detected in most of these entities, and up to 75% of these entities have a complex karyotype, including at least one structural abnormality. The mutations, however, are different from our case. So genes that are involved in epigenetic regulation are often found to be mutated in BPDCN. So that's often you'll see TET2 ASXL1 mutations, which we didn't see in our patient. Genes involved in RNA splicing are also mutated. So you can see the list there. And then others, such as NRAS, KRAS, and ATM, are mutually exclusive. So ours had 3 NRAS mutations, which could be in keeping with BPDCN diagnosis. Okay, so in terms of the diagnostic criteria, so the essential criteria involve immature cells with a blastoid morphology and PDC differentiation. And so we have immature cells with a blastoid morphology, and they show partial PDC differentiation. I'll explain why. So, and then this is from the 5th edition of the WHO. So in terms of desirable criteria, you want absence of lymphoid or myeloid lineage markers. So that would be cytoplasmic CD3 or MPO lysozyme. You want absence of CD34 and a high Ki67 proliferation index. So in terms of the markers of PDC differentiation, you want the tumor to show CD123 staining, which we have conclusively shown. In addition, you would like to see TCF. So in terms of the diagnostic criteria, you want to see CD123 as well as one other PDC marker. And so it can be any one of TCF4, TCL1, CD303, or CD304. Unfortunately, we do not have access to CD303, 304, or TCF4. We do have TCL1 by IHC, and I will show that to you. We'll get to the TCL1 basically. The other thing that you expect to see in BPDCN is CD4 expression as well as CD56 expression. So I've held back the CD56 and TCL1, and you will see why. So expected negative expression, which we've proven in our case, CD3, CD14, CD19, 34, lysozyme, and MPO. And then, as I said, I just went through the diagnostic criteria. The other way to get to a diagnosis of BPDCN is expression of any 3 PDC markers and absent expression of all the expected negative markers. But as I said, that's difficult to do in our case because we don't have access to TCF4, CD303, or 304. Okay, so in terms of prognosis and treatment of these cases, unfortunately, the median overall survival is quite low. So it's about 9 to 24 months. In terms of targeted therapy, there is targeted therapy for this currently. It's CD123 targeted therapy, and there have been increases in response rates and overall survival seen with this therapy. The other option is treatment with BCL2 inhibitors. And this can be done either alone or in combination with hypomethylating agents, chemotherapy, or anti-CD123 therapy. And ideally, what you would like to do is, in eligible patients, you'd like to get them into first remission to then follow up with allogeneic hematopoietic stem cell transplantation, because that offers them the greatest chance of increasing their overall survival. Okay, so the other leukemias on our differential, given what I've shown you so far, are also acute leukemias with a KMT2A rearrangement. So interestingly enough, KMT2A can be seen in several different types of leukemias. So it can be seen in acute myeloid leukemia, in B lymphoblastic leukemia or lymphoma or BALL. It can also be seen in TALL, but it's not necessarily diagnostic for an entity in the WHO currently, and then a mixed phenotype acute leukemia. So I'll just quickly go through this. So in AML with KMT2A rearrangement, it's fairly rare. It's only seen in about 2 to 3% of AML cases, and it usually involves the blood or bone marrow. Extramedullary involvement does occur, so you can see skin lesions and gingival hypertrophy, and that's identified in about 1/3 of adult patients. And more than 80 fusion partners have been described for KMT2A, and actually it's gone up to over 100 now. So I think that as more and more people are sequencing and carrying out advanced sort of cytogenetic assays on these cases, more and more fusion partners are coming into play. So in terms of the more commonly rearranged genes, MLLT3, AFDN, ELL, and MLLT10, similar to our case, are most commonly rearranged. And in terms of the rearrangements, they can occur through any number of chromosomal changes or gene changes, including deletions, duplications, inversions, as well as translocations. And they usually disrupt a region in KMT2A between exons 5 and 11. And then basically when you get the fusion gene being produced, what usually happens is you have the KMT2A promoter and coding regions 5' to the break point, and it causes a chimeric protein to be produced, which is has a KMT2A amino terminus, and then the partner is basically the carboxy terminus. Okay. So interestingly, AML with KMT2A rearrangements should have a low tumor burden, and they usually have mutations in genes encoding the RAS pathway, so NRAS, KRAS, PTPN11, and which is what we also see in our case. So we mainly had NRAS mutations in our sample. Other genes that have also been detected include FLT3-TKD, RUNX1, TET2, PLCG2, and ZRSR2. And interestingly enough, the NRAS, so the RAS pathway mutations and FLT3-TKD often occur at very low VAFs, indicating a subclonal nature, which is what we see in our patients as well, because even though we had 80% of the specimen being involved by this tumor, the NRAS mutations had very low VAFs of 10% and lower. Other common mutations that can be seen in normal karyotype AML, such as NPM1, CBP alpha, as well as DNMT3 and FLT3-ITD mutations, are less common in this entity. So in terms of the diagnostic criteria, KMT2A in an AML is diagnostic for a leukemia, even in the presence of less than 20% blasts, which is interesting. And the blasts have to express a myeloid immunophenotype and cannot fulfill the criteria for a mixed phenotype acute leukemia. And they cannot fulfill the criteria for myeloid neoplasm post-cytotoxic therapy. And this is because topoisomerase 2 inhibitors actually cause DNA breaks that can lead to the production of KMT2A rearrangements. And so that would fall under the category of a therapy-related myeloid neoplasm. And then desirable would be identification of the fusion partner. And that's, you'll see that repeated multiple times. So in terms of other leukemias that have KMT2A rearrangements, so BALL commonly has KMT2A rearrangements, and it actually accounts for a large majority of leukemias in infants that are less than 1 year old. And it becomes less common over childhood and then starts increasing into adulthood. They have a very interesting phenotype because they may be 19 positive, 10 negative, and then sometimes they're TDT negative, which makes them difficult it can lead to diagnostic difficulties, but they can also show positivity for myeloid markers such as CD15 and 65. As well as a neural antigen, which unfortunately we don't have access to in our lab. In terms of molecular findings, so more than 90 cases have one of these 7 partners, and you can see that it's some of the same players. And then in terms of the criteria, the entities should meet criteria for basically a lymphoblast of B cell derivation. And so they should express B cell lineage markers, so 10, 19, 22 is 79A. And if you're seeing this in the tissue, they should also express markers of immaturity, such as TDT 34 and 10. The lymphoblasts in the bone marrow will also show markers of immaturity. Rare cases are CD34 and TDT absent, though. And then, as before, you need to demonstrate KMT2A rearrangement and ideally identify the rearrangement partner. And then similarly, MPAL is the same. Patients present similarly to other leukemias, often with cytopenias, as well as involvement of blood, bone marrow, or skin. MPALs with KMT2A are quite rare, and they're often found in infants. And then there are 3 common partners. These also show a low mutation burden and very few copy number alterations. And some of the rearrangements are quite cryptic, and so multiple modalities may be needed in order to actually identify the rearrangement. So there are some rearrangements such as KMT2A, USP2, and USP8, and they can sometimes be difficult to detect without unless you're using multiple modalities. So they may be missed on karyotype. Similarly to the BALL, if you detect it in bone marrow and blood, you would like to see over 20% blasts. Here, you want the immunophenotype to meet the criteria for MPAL. So you need to see either one of CD3 first T cell differentiation. You need to see markers for B cell differentiation and MPO for myeloid differentiation. And oftentimes the MPAL that is associated with a KMT2A rearrangement is a B myeloid blast. So you would see B cell differentiation as well as myeloid differentiation. You need to see the KMT2A rearrangement and no history of exposure to cytotoxic therapy. Interestingly enough, with KMT2A rearrangements, often after your first cycle of chemotherapy, sometimes, especially in these MPAL cases, you might get a lineage switch, And in the BALL, sometimes you might get a lineage switch as well. So it seems that the KMT2A rearrangement is affecting a very lineage pliable cell or a progenitor cell that has some sort of plasticity, and you see sort of these blasts that can have both myeloid and lymphoid features or phenotypes. So what about our case? So as I said, I held back CD56 and TCL1. So our working diagnosis was that this was going to be a BPDCN. But the 56, unfortunately, is negative in the immature cells, as you can see here. And unfortunately, the TCL1 is also negative. There's like a weak blush staining that you can see, but this is non-specific staining. It's negative. So we don't actually meet the criteria for a blastic plasmacytoid dendritic cell neoplasm. And it's difficult to make that diagnosis with the lack of 56 and additional PDC markers. So the other option is to consider an AML with a KMT2A rearrangement. So once I conclude the presentation, feel free to let me know your thoughts on this. But I will say that I reached out to the author of the chapter in the WHO with regard to our case, and they had their own thoughts. So I can leave those for the end, so that we can have like a little bit of a debate around this. But I will let you know what they think. And then finally, I just wanted to touch a little bit on targeted therapy. So this is fairly new. So as I said, KMT2A is oh, actually, I might not have said so. Sorry. It's a histone lysine methyltransferase. It's an epigenetic modulator of several target sequence, including HOXA. And HOXA is associated with another gene, MICE1, and basically upregulation of both HOXA and MICE1 lead to a differentiation block in hematopoiesis, and then it actually and in that way, it's leukemogenic. So rearrangement of the KMT2A gene basically causes loss of the wild type C terminus and generation of a fusion protein that leads to dysregulation of the target genes, leading to upregulation of HOXA and MICE1 and thus leukemia. So the targeted therapy is actually not direct. So it actually affects another protein called menin, which if you remember from our clinical genetics rotations, is the protein of interest in the MEN syndromes. So here, actually, menin is involved in KMT2A targeted gene regulation. And so between menin, KMT2A, as well as another protein known as lens epithelium-derived growth factor, basically disrupt, between if you disrupt the interactions between these proteins, then it basically leads to downregulation of the HOXA MICE1 program, and then it abrogates the generation of a leukemia. And so that's basically how this targeted therapy is basically it works. And so for patients who have a KMT2A gene rearrangement, it's thought that a menin inhibitor will then help potentially, break the block in differentiation and allow the hematopoietic stem cells to then go on and differentiate into mature hematopoietic cells and lead to hopefully a cure. So that has been shown in cell models. So there's a new phase 1 clinical trial for a menin inhibitor known as revumenib, and it's basically an oral selective inhibitor of this entire menin KMT2A reaction. So it's a small molecule inhibitor. And then in mice models as well as PDX models, they've shown that disruption of this menin KMT2A interaction disrupts the HOX-A mice 1 upregulation and is actually anti-leukemic. And so based off of these tests and models, there was a recent first-in-human clinical trial that was just published. Actually, it was published last week. And it shows that this small molecule inhibitor may actually be of use in patients who have KMT2A rearranged leukemias. So although the majority of the patients in this trial were relapsed refractory AML, they did have a handful of patients with lymphoblastic leukemia, as well as I think at least one patient who had an MPAL. And so among this group of patients, and I think it was about 60 or so patients, they had a rate of complete remission or complete remission with partial hematologic recovery of about 30%. But here it was among the MRD negative evaluable patients. Cytogenetic response was about 64% of patients in morphologic remission, and with additional cycles of administration of the drug, that basically any patients who did have persistence of the KMT2A rearrangement, you could actually see it going down over time. The median duration of response was about 7 months, and but the good news is that 12 patients actually were in complete remission and then actually received an allo transplant, and were still in remission at the time of data cutoff, which is fairly good news. In terms of adverse events, which was really the point of this trial, was to document the adverse events in these patients. So in addition to, nausea, vomiting, typical adverse events that you might see on treatment, one of the interesting adverse events that did occur on this patient, did occur in this patient population was prolonged QT intervals on ECG, mainly asymptomatic, as well as differentiation syndrome. So as predicted, if you do disrupt the whole KMT2A menin interaction, it actually unblocks that entire path to differentiation, and about 15%, 16% of patients actually underwent differentiation syndrome. So about 11% of patients, sorry, not 11%, 11 patients were documented to have differentiation syndrome, which were then treated with steroids, and about 5 of them had leukocytosis requiring hydroxyurea as well. But with treatment, it completely resolved. So that's interesting news and something coming down the pipeline. So patients who have KMT2A rearrangements, which are often also a poor prognostic disease, may have options for them if they in terms of therapy. So in terms of our case resolution, our patient underwent therapy with azacitidine venetoclax, so BCL2 inhibitor, as well as a hypomethylating agent. But unfortunately, he developed febrile neutropenia and respiratory failure after 3 cycles of therapy, and he subsequently went into multi-organ failure and passed on. So it's unfortunate that he couldn't get to clinical trial because it would have been interesting to see whether or not a menin inhibitor could have helped in his case. So that's the case. And yeah, I'm open to any questions or any discussion about the patient or the findings.